alterations in our scheduling, if you will. As you joined us and you just saw Paul had his day in court, he was actually being recognized by the Dallas County Commissioners Court with the county judge providing a proclamation for his lifelong achievements and culminating in recognizing the award for EMS Medical Director of the Year as presented by the National Association of Emergency Medical Technicians. And one of the commissioners actually sponsored the proclamation. It's very nice. I'm sure we'll be able to share it online and we'll put it up there for people to read, but it covers a little bit of Paul's history and therefore be it resolved that Dallas County Commissioners Court does officially recognize and congratulate Dr. Paul E. Pepe, MD, MPH, upon receiving this well-deserved recognition and appreciate his outstanding work and commitment to Dallas County on the first day of September 2020, and signed by Judge Clay Jenkins and the county commissioners. And so it's always great to see one of our own, especially our leader, be recognized formally, and it shows the close ties and relationships in not only our world of EMS and fire, but also public health and the interactions with our local elected officials as well. So congratulations to Paul, and looks like he's going to join us here in just 1 second. And I'll bet that he has not changed his non-essential t-shirt between the presentation and here. So we'll give him a minute or two to get on for us as we move forward. One of the areas we did want to spend a little bit of time would be talking about the ketamine issues, and as Stein and I don't know if Kevin was able to get on, we'll start to have that conversation. But Paul, congratulations. And I don't know if you...
It was interesting, it's all I could say.
Well, thanks to technology and Peter's screen sharing, we were able to listen in and watch you receive the proclamation and your remarks as well.
Oh,
so
good.
we all got to see that. Okay? You know, technology issues are always a little hard, but we made it work, and it was really nice to see you there in front of Commissioner's Court. So we said that you had your day in court. We were going to preface it that you were initially in court for a hearing, but we didn't quite get to do that this morning.
Good for you. That's great. Hey, let me go through the list who's on before we get started here. And Crawford, why don't you be prepared to start your presentation on the violence issues? And then trying to see who's Mike out there. There's someone, it just says Mike. I don't know who that is. So if you could tell me.
I'd be Mike Levy.
Okay, good. Thanks, Mike. Okay. Is that Michael K. Levy? That one? Okay, good. All right. Thanks, Mike. And then who's area code 215? Is that just another connection for you, Crawford?
I'm 215, Paul.
Okay, yeah. Okay, got to make sure that was you. And then 512, is that you, Warren, by any chance? Who's 512?
Paul, it's Jeff Hayes.
Oh, Jeff Hayes. Oh, 512. Okay, I screwed up. Okay, yeah, Jeff Hayes. Okay, thanks. That just helps. I like to know who's on. I can call on you guys and so on as needed. Hey, does anybody have to be off, say, by about 11 o'clock? We're going to get into some heavy stuff after 11 with Mike Osterholm joining us. Anybody have to get off the phone, before then?
Yeah, it's Kevin. I need to get off relatively soon.
Okay, good. We'll focus on you then. We'll talk a little bit about what's happening in that end of the world. Just want to see who else is here.
Hey, Paul, Andy, I got to jump in about 15 minutes too.
Okay, got it. Thank you, sir. Okay, and
Yeah.
Sandy, how's your timing? Sandy Schneider, you're muted. Hey, so anyways, you, Dr. Gautreau, you have to get off early too as well?
Well, I'm working clinically right now, so I'll be in and out.
Got it. Okay. As many of you that can, as many of you that can be on and stay on, really appreciate it. It's going to be, I think it's going to be great, particularly after 11 o'clock when Mike Osterholm gets on. I've asked him to address a bunch of stuff, etc. And then we have to continue our information. And Fiona, good to see you, or hopefully see you anyways in a second. And great to have you on. And there's the iPhone, Mark G. Is that you, Mark Gautreau? Is that right? Or yeah. Okay. Good. All right. Thank you. That's all I need to know. All right, so why don't we go ahead and get started here, and then if you don't mind, Kevin, why don't we go ahead and take you, since we know you got to go, and let me know what's going on in your end of the world.
Well, should it be, but Stein had prepped this. Stein, do you want to lead into this, or do you want me to describe what's going on?
Well, I'll just say that I did kind of forward information to people about what was going on. I feel as though timing is imminent on some of these issues, and I really wanted to try to get you on this meeting so that you could explain it right from the Denver Metro position. So go ahead.
And before we launch into that one, Kevin, since I know where we're going on this, let me just see, just let me ask Andy Garrett, since he's got to get off pretty soon. Andy, anything you want to pipe in about? Because this is going to take several sessions, I think. We're going to move into a couple of, it's going to take some time to go over what we need to go over. Anything, Andy, that you want to contribute in?
Oh, thanks, Paul. Nothing major from HHS. Deployed down to the Louisiana coast. We have 3 full DMAT teams down doing hospital decompression missions for facilities that lost their utilities and or their staff. Been in the field since Saturday, so we're at full operations now, and moderately busy. The acuity you'd expect on the order of 5 to 10 lacerations a day, that type of thing.
Yes.
Carbon monoxide kind of stuff has dropped off, which is good. They had a big bump of carbon monoxide related injuries the first.
Oh, I heard about that. People put their generators inside the house, right? It was great. Okay.
But it's good. This is the first time out with a major new revision to the DMAT cache, so we're running almost all new equipment, and it's beautiful. LifePak 15s and hot stuff. One of the major limiting factors right now is the iStat CLIA cartridge recall, so we are really limited with our labs that we can run. But other than that, good relationship with the hospital. It's nice. It's sort of how it's supposed to look, I think. And,
good. Okay, great. Well, then, thanks again for your great work.
I just wanted to check in. I'm working a shift, so I got to go back to the tent. But
okay,
just to say hi.
I understand. Shifting dullness awards here. Okay, it sounds good. Thank you so much for your help there.
Yeah, no worries. Thanks, guys.
All right. Hey, Sandy Schneider, how's your time looking?
I'm leaving at 11. I'm sorry. I have a standing meeting that periodically goes up.
So we're going to kind of weigh in, I think, now a little bit on the ketamine issue. So I want to make sure I get you on. It's 10:42, guys. So if you can get finished whatever parts that you guys have as lead off in Colorado, get to her. And then Mike Levy, I hope you could be on and give a response from the NASP realm. Okay, so that's it. All right. So let's go ahead and get back to Stein then, and Kevin, whoever wants to take it over.
I'll jump in, and I'll try to be really brief because there's no sense in dragging anybody else into the local politics, but I'll try to keep it to the big picture things. It kind of it basically went mainstream in Colorado, starting with Denver in 2013. That in Denver, we developed a multi-agency excited delirium protocol with training from fire, police, 911 comm center. And with that, ketamine was part of it. Remarkably, we are having a death or two about every year from somebody being held down. And since we implemented this in 2013, we've had 0 deaths. Now, a neighboring city, Aurora, had a death that made national news, and whether that's ketamine related or not, we don't really know. But basically, it's been in Colorado, 7-8 years without a death from this type of event. There's a lot of local activists, and they're getting a lot of fuel from a very, very prominent anesthesiologist in the local area, that this is egregious, it's a human rights violation, that police are using the medication to facilitate arrest. We're trying to combat this, but in the media, there's nothing to be won. In fact, my institution has requested that I stop talking to the media because they just feel like it makes a target on our institution. The state of Colorado pulled together an investigatory board that's separate from the whole state EMS structure, and then is putting an anesthesiologist, a pharmacologist, a toxicologist, and as best I can tell, they're not putting an EMS physician on this, which is remarkable that there's a boarded subspecialty that is most informed on this that is not being allowed. So we're fighting this on a number of different levels. I think things that really help are the Eagles position paper, which when I looked on the website, looks like it had been taken down. The Eagles position paper, and then the ACEP and ASA combined statement, I think is helpful. But mostly we're fighting non-medical people who are very, very passionately stepping into a medical realm. And I can just sort of leave it at that.
So, you know, you can see the comments by people like Mark Eckstein and all that. And Sandy, I had some feedback coming from other circles. Mike Levy can probably articulate that better. And then I want to have you maybe react to that as well. So Mike, so as our incoming president of NAMSP, any thoughts from your end or the people you've talked to regarding this?
Well, I guess I could say, I don't want to put Sandy on the spot, but maybe I need to be better educated. I think overall the input we are getting was a significant disappointment that ACEP teamed up with ASA in a statement that wasn't false, but the optics on it were bad, which was a statement that, I don't have it in front of me right now, but it's not far away, that basically said that they both, ACEP and ASA said they did not condone the use of kind of law enforcement use of ketamine or something, which is none of us do. But in this context, the optics on it we thought weren't necessarily the best. I'm happy to hear that Kevin and perhaps others see it in a different light. So NMASP is working with our publication side, our publicist side, our public communication side, to craft some messages to, you know, just basically advocate for the fact that people need to stay in their lanes. I guess is not how we're going to say it, but the context is that EMS physicians should be directing this in context of ongoing QA and the like. And my thought about it right now is that we need to steer away from the word ketamine and talk about just generally how we deal with combative patients and how we protect safety for patients and providers. Thanks.
Right, and I think Chris Colwell kind of articulated it nicely in terms of saying is that, you know, the optics of situations that require ketamine are almost never good. But the main thing was I think had to do with some of the dosing issues and all that stuff. And what it comes down to here is like, you've heard my theme for the last 3 or 4 years is that only a Sith deals in absolutes. In other words, it's not something's good or bad. It's when you use it, how you use it, for whom you use it. And if you look at the big picture, there's probably 300 times a day in the United States where this works and does great things for people in the pre-hospital setting. And then every once in a while, something like this comes out, just like everything else. But in any event, Sandy, go ahead and give things from your end of the table as well.
Yeah, so I'm a little bit concerned about the interpretation. We actually went back and forth with ASA many times. As you know, they had set out an original statement that said that ketamine should not be used by law enforcement. And it was a pretty negative statement. The current statement that we worked with them on, and it went as a significant back and forth, probably 30 iterations. And I know that Brent Myers was in for some of the early ones. He may not have been in for the very last one. But this is the statement, and I'll read it to you and put the link in. It says, ketamine is a dissociative anesthetic. If you recall, their previous one said ketamine was a dangerous drug that is widely used in the emergency department and in pre-hospital care for effective pain relief, sedation, the control of delirium, and acute psychotic emergencies and drug intoxications. Its safe use in pre-hospital care is dependent on an appropriate medical assessment by a paramedic with medical direction, guiding appropriate dosing, monitoring as soon as feasible, and timely transport to an emergency department for further assessment and treatment. ASA and ACEP firmly oppose the use of ketamine or any other sedative hypnotic agent to chemically incapacitate someone solely for a law enforcement purpose, and
Yeah.
not a legitimate medical reason.
Yeah.
So that's what we wrote. I am a little bit concerned personally that this is being interpreted as being anti-EMS physician, because we certainly didn't mean it to be that way. Clearly, this is compromise language, because if you read the original ASA one, it was pretty nasty, and it took a while. But Paul, please.
No, I think I agree with you, because I know the context where they just came out and, said we're in charge of ketamine for the world, and this is what it is, this is evil. I think when you got down to the fact, and I think this is actually what CNN was showing last night, if I remember correctly, was that it was the police said, hey, let's, can you guys give him something? And at first the guy said he's fine, he doesn't even have to go to the hospital. Then they're going, hey, can you give him something? So that's what really kind of made this a little bit goofy, especially when they put in their report that the guy was delirious, later. So I don't know if he changed in front of them or what happened here, but it really complicated things. So the optics with the police is what the issue is there. And I think you addressed that nicely in a way, okay? So maybe we need to take it to the next level as well. But I think I personally think, knowing what you were faced with, you ended up getting a good compromise. So, all right. So.
But again, I don't want to cuss. Mike, I'm really concerned that, NAMSP would find this, and I'd like to make sure that we don't do something. But, just putting in the chat, 60 Minutes is all over this. We've been working with 60 Minutes, both inside and outside of 60 Minutes. NPR, all of those groups have been talking to our PR department. One of the problems we are seeing is that a lot of them are reading the original ASA statement and using that, and that is extremely negative, and was one of the reasons why we came out with this joint statement.
So let me do this. I'm going to run on I'm going to take a couple of comments I see in the list. I just want to bring them out. And Corey, let's start with you, Professor. You're always so bright about this stuff. If you don't mind, can you jump in, Corey Slovis?
Sure. Reading some of the comments, what Mark Eckstein is talking about, objective data, and what others are talking about, unified voice, I think both are essential. And long before ketamine was in the field or in any of our ERs, we were seeing deaths from excited delirium during the early cocaine epidemics in the 80s. And we ought to talk about the fact, I guess it's such a huge issue. We ought to make some bulleted points that are clear, that are beyond refute, that bring up the most important points in an articulate way, and stay unified in what we believe in. And certainly 500 plus milligrams at a time without medical oversight is not what we endorse.
Yeah. So, hey, Corey, is this what you mean by you could be both pro-choice and pro-life? Is that right? So you can choose ketamine when you need to.
It's kind of like early TPA or early opening of the artery. You can be both pro-life and pro-abortion as long as you're talking about acute myocardial infarction.
I know, it's great. So thank you so much. Great. Hey, then you want to pipe in then, I guess, Mark Eckstein, let's go ahead. Because I like what you said was about everything that Sandy was just saying, which is that as long as it's under medical oversight and well controlled, it should be, that's the way to go. So do you have anything else to add to that, Mark? Oh, I don't know if Mark can hear us anymore, if he's out.
Hey, good morning, everyone.
Yeah. Hey, Mark, how are you?
Good to see everybody, even though it's virtual. Obviously, we need to stay above the fray, but we can't ignore the political reality right now, and optics are important. I think there's a paucity of data, and the data that exists out there is troubling. One study that reports over 30% or 40% incidence of intubation in the emergency department of patients who got pre-hospital ketamine is problematic. And the dosing issues underscore the need for close medical oversight. I think the discussion has to be framed like some of the points that were just raised, including those by Corey, in that excited delirium is real. It used to be crack and PCP, and now, at least down here in LA, it's all meth. We see this several times a shift, all day long in Skid Row. And this is an issue for the patients, safety issue for the first responders and law enforcement. We use Versed here, but we don't use ketamine. But whatever it is, close medical oversight, monitoring, QI and peer-reviewed data is important. And to get out in front of this, the well-publicized case from Aurora, someone has to say, you know, without throwing the medics under the bus, that dosing is important. So when the report that the kid was 140 pounds and got 500 milligrams, I don't know if that's true, but I think any physician, particularly outside the EMS lane, will think the medics are giving ketamine and just use it at will with no medical oversight fuels the fire. So a unified voice is important, but I think everything has to be metric driven with peer-reviewed data. So I would reach out to colleagues who've been using ketamine for a while in Minnesota and Colorado and other jurisdictions, you know, pool your data and at least publish a review, even though it's going to be retrospective, if you have outcome data looking at morbidity, mortality, intubation rate, and so forth, and then frame the discussion about untreated excited delirium, you know, is associated with very high morbidity and mortality.
Well, I think that's kind of what we are doing right now, because we are, like, for example, Brent's going to come on later on and talk a little about the state of the publications. I think specifically Remley, who I think Remley's on, she can talk about where we are on putting those data together and putting it down and articulating it. And then while we're at it, Corey, if you just on the side, just off the top of your head, without any other influences of what we're hearing, is just put down what you think those bullets should be, you know, and just send it off to us, and we can use those or work around that and use it, just something we can use as a straw man for now. Because I think what you said was really great, because we do need talking bullet points, you know, as we get through this. Okay. So, all right. Remley, where are we on that, or should we come to that later on, you think, if you're here, Remley?
I can give the quick view of it right now. We're planning to submit at least 2 abstracts, one just describing ketamine use overall to help dispel the myth, you know, that ketamine's only used for this chemical sedation thing. No, it's by and large used for pain, actually. And then we can quickly dispel the myth of, oh, ketamine's being given and these patients are not being taken to an appropriate medical facility. 99.9% of the patients are actually transported. So we're going to submit those to NAMSP, and we're asking for permission to be able to share them earlier than we would. You know, normally we'd have to embargo till January, but we're in talks with NAMSP to try to see if we can release that a little bit earlier. And then
I'll jump in for 1 second, Paul.
Yeah, go ahead, Corey.
In pre-publication form, but available online, in pre-hospital emergency care is the position statement by ASAP, NAEMSP, national EMS educators, etc. The bullet points are all there. Their position paper is on trauma. I think we just choose carefully what we like there and pull some of it and apply it to everything we're doing.
Okay, sounds good. If you feel that's the list you would have supplied us, that's
we all ought to just take a look at the article. It's on the website in press. And what they've done there is talked about dosing, monitoring, using it appropriately with medical control.
Yeah, okay. All right, and then Remley, what were you saying before I want to keep going, but you had talked a little bit about the good paper in forensic science. What's good about it?
I think that just sometimes we're not thinking about the other comparison group. So we are not talking about what happens if the patient wasn't given ketamine. And that paper actually looks at restraint without sedation and shows worse outcomes for patients who are just physically restrained.
Yeah. And so Chris Colwell, since you started all this, by the way, you know, out there in Denver, wasn't that under your watch, right? So Chris, any comments you have?
I'm not taking responsibility for all of this, but we did have a good experience, and I think the points have been extraordinarily important. We were really running into, you know, remember that summer of 2013 was the Black Mamba epidemic, and we were running into very high numbers of patients that were coming in excited delirium and getting intubated in the emergency department. When we instituted ketamine, those actually intubations, while still high, were actually lower than they had been before the institution of ketamine. And those are the types of things that don't come out, and particularly when we have anesthesia that's at front of this, that don't do EMS medicine, that don't understand pre-hospital medicine. We don't hear that side of the story, and people are starting to talk about what happens if we don't sedate, what happens if we're not aggressive about stopping the spiral that happens with excited delirium. And so I agree with everything that's been said. It absolutely has to be with medical oversight. It cannot be for law enforcement purposes. But this is a potentially extraordinarily important drug. And we can't also let the fact that these are very tough situations, and like with droperidol and other drugs, that they've been around when bad things have happened. We can't let that be the driving force. We've got to use that science and this unified voice to say, in the right setting, this is an important drug. And I agree with everything that people have been saying.
No, so anyways, I actually hear kind of a unified voice here in both sides, and the representation from NASP and those are. I mean, I think we're all there. Some of this is very sensitive, and we are. We're getting together and we are unifying here, I think, and everybody's more sensitized to this to make sure we get through it together. So we'll work on that a little bit closer, but this has been a really good discussion. And now, Joelle, did you have to get off, or are you already off? Because I think what she said here is that this is a good example why we're here, that EMS medical oversight needs to be there, and it's the reason why it's needed and how it has a unique setting and risk that we have. So I like what Terry Valenzuela said before. What you guys are telling me is that this is a very dangerous situation that we're often treating. The issue here was in that particular video I saw last night, the medics were telling the cops that what I saw was that they were saying, oh, he doesn't even need to go to the hospital. And so these guys, the law enforcement guys, to give them some due, we're saying, well, how do we control him better? Can we, give him something in the interim? So then it got kind of murky there. So I think it just was an unfortunate situation that shouldn't have happened from everything I'm ascertaining. Again, it's got to be investigated and done properly and all that. But I'm just saying, I think that's part of what happened here to some extent.
Hey, Paul?
Yes, go ahead, Peter, go ahead.
Yeah, I think that defibrillators kill a lot of people. I think we need to look into this.
Yeah, you got it.
Over 90% of people die when we defibrillate them. So there's something, that machine's got to go.
That is
got to go.
I think that's probably why tasers were killing people too. That's the electricity. I think that's what it is.
And sometimes we use a lot of electricity.
Only 6% die from the defibrillator. 94% died from something else. So
all right, got it. Okay.
Corona.
It's Corona. You mean the beer? So, all right. So listen, let's move on. Hey, Amal, do you have anything for us cardiology wise? And Peter, you're gonna, and I want Crawford to be ready, and then I want line up Peter for his presentation on anti-gin testing, right? So
yeah, thanks, Paul. There's nothing really groundbreaking, and in the interest of time, I'll just defer it to the other folks, but more of the same has come up in the literature, nothing new.
Okay, good. Well, thanks a lot. And then thanks a lot for getting that anti-coag thing for me. It really set up the thing that we're doing, that we need to do platelet mapping. So, because those guys were just indiscriminately given the heparin, thinking they were doing a good thing for coagulated people. So thank you so much for getting that for me.
Great.
Okay, so let's see. Hey, Mark, it sounds like you have to leave, but thank you for your input. It's great to have Mark Eckstein on board. So let's move ahead. Let's start with Crawford. If you're ready to go, Crawford, do you want to screen share or something and tell us a little bit about just leading our discussion about the increase in shootings and stabbings? As we said, we might want to look at penetrating injuries, but give me your impression from the Philadelphia area. And by the way, just before we get started with this, for those listening in or going to be listening in on the recordings, this is a gathering of the Eagles, the jurisdictional medical directors for the 40, 50 largest or so cities in the United States and their counterparts in Europe, Australia, and other parts of the globe. And we've heard already from various people, including Kevin McVaney from Denver, Chris Colwell from San Francisco, Mark Eckstein from Los Angeles. I probably left out a bunch of other people, Stein from Colorado Springs and so on, and Corey Slovis from Nashville, and I forgot, I could just go on. But in any event, thank you all, and I want to orient you. So the medical director for Philadelphia is going to be coming on, and if you don't mind, hit it, Crawford Beecham.
Yeah, hi. And I apologize, I'm too technologically challenged to have anything to share, so you're just going to have to listen to me.
That's what we heard about you. Okay,
I can't be fixed at this point. So we've all been discussing the whole issue of penetrating trauma. The whole issue of penetrating trauma. Is that me or someone else? Oh, sorry.
That was me. I turned it off now.
Okay, fine. All right, so we've all been seeing, most of us have been seeing increased penetrating trauma during the COVID pandemic. And in the past couple of weeks, a couple of publications and pre-publications have come out of Philadelphia, which I will share when I'm done, discussing how trauma centers in Philadelphia have sort of adapted to this whole situation. Just setting the stage a little bit, Philadelphia is the 6th largest city in the country. We have a lot of challenges. For example, we have the highest poverty rate of the 10 largest metropolitan areas.
Wow.
Historically, it's been in the roughly 25% range, and it's just not getting any better. We have the second highest homicide rate among the top 10 largest cities. Fortunately, there's still Chicago to outdo us. As of mid-August, our shootings in Philadelphia were up 36% compared with the same time last year. As of yesterday, hot off the press, we broke 300. We're up to 301 homicides for the year so far. It's up 31% from the same date last year. Last year, we reached that number, I think, at the end of October. And there's a close correlation, and this is not unique to us probably, between where the shootings occur and the highest poverty areas of the city. And there's a close correlation between the highest poverty areas of the city and the areas most heavily impacted with COVID. And there's also, not surprisingly, a correlation between crime and our high opioid use areas. So it's sort of a very tangled web we live in. A little bit more context, Philadelphia transports 9 trauma centers, 2 of which are exclusively pediatric. So the question becomes, how did our trauma centers respond to all of this, and how are they doing now? So during the first month and a half of the COVID outbreak, so kind of March, April-ish, the Philadelphia's level 1 trauma centers saw an overall drop of 20% in number of patients there. So not just trauma, but just kind of all comers patients. During that same time, the same hospitals admitted more than 1,400 COVID patients, and a quarter of them required ventilators. So overall numbers were down, but they were getting a lot of COVID patients, and many of them were very ICU and mechanical ventilation dependent. Among these trauma centers, Penn's trauma center, which is now Penn Presbyterian, saw a 20% increase in penetrating trauma victims. Despite COVID and despite the increase in penetrating trauma, the level 1 trauma centers in the city were able to keep their diversion hours to less than 2%, which is fairly remarkable for us. And most of them were open to interfacility transfer of trauma patients the entire time. So clearly they were doing something appropriate to respond to this new issue. And what they did was pretty much, most of you have probably seen the American College of Surgeons Committee on Trauma guidelines for trauma centers during the pandemic. And so they did the normal things. They canceled elective surgery. They safeguarded their staff by limiting exposure during resuscitations and procedures. They made sure they had enough PPE and blood products. They modified how they did trauma airway management. And they looked for alternatives to ventilators just in case the concern for ventilator shortages actually happened, which fortunately it never did. They did something a little bit unique for Philadelphia, at least. Like many big cities and big systems, we have large and powerful health systems in Philadelphia. There are pretty much 3 or so, but they actually work together. They regionalized trauma care in the city. So they had weekly teleconferences regarding COVID numbers, trauma patient numbers, what individual hospitals' surge capacity was like, how much PPE they had, and what sort of clinical lessons they were learning during this experience.
Nice.
And they did something a little bit different where we have, like I mentioned, we have 2 pediatric trauma centers. And so the adult trauma centers actually began transferring younger trauma patients to the pediatric centers. And so in Pennsylvania, in the eyes of the EMS protocols, you're a kid up until the age of 14, and then you become an adult, which seems awfully young. But that, and EMS in Philly at least sort of ignores that cutoff age. But the trauma centers began working with the pediatric trauma centers to transfer patients age 17 to 25 from essentially the adult trauma centers to the pediatric centers, because pediatric hospitals in Philly, like in many other parts of the city or the country, were not as heavily impacted by COVID. And so they had the room. And so some of the adult trauma patients were being transferred to the pediatric centers. And so that's kind of how they've adopted. Like I said, I'll share the publications which go through this in detail. Fortunately, our COVID numbers are way down for the time being. Our shootings continue to be up, but kind of through a combination of interventions, trauma centers have managed to kind of hold their own through this, and hopefully things will just start getting better from here. So that's all I got.
Okay, great. Thanks very much for the report. And so the trend in New York City, Glenn Santa, of course, from New York, was almost on double pace. How's that going still at this point in time? You still pretty much, you're way above where you usually are. Where are you now? What pace are you going at?
Yeah, you know, COVID is working out for us now, but the traumatic shootings in particular, are still not great. This weekend, we hit over 1,000 shooting incidents. All of 2019 was 774. Already we're at over 1,000 now. This past weekend, we had over 24 shootings. So that trend is going up. You know, there's some accusations with the defunding of the PD about PD slowdowns and such that's been in the media. You may have seen that. Of course, the police department's denying that. They did cut back on overtime, is what something the department had, the chief of department for PD had reported. That actually overtime has been, access has been granted again starting, I think, yesterday. So we're going to see how that changes things.
Okay, good. Thanks a lot, Glenn. Hey, and I don't know if you're on the line still, Erica Carney, because I know you guys were hit pretty hard or still being hit hard. You know, it's interesting, Glenn, as I'm getting Erica on, if she's hearing this, I mean, the pace you're at, if I'm prorating it quickly, doing the math on my mind, since this is only September 1st, when we got September, October, November, December, 4 months, you're on pace to be double what you were doing before. So
yeah, I think that's where we're headed.
Yeah. Okay. And Erica, by any chance, are you on? Because I know you guys were getting hit hard in Kansas City as well. I don't know if you can report on that. Yes.
Yeah, I apologize. I heard my name earlier and I was on a call because I've been exposed now apparently at our academy. So, but in regards to penetrating trauma, we had a 30% increase about 2 or 3 weeks ago, and same as other comments that have been made, we hit our record high for homicides for our region as well. I have not pulled the numbers this week yet, so I'm not sure if we're still at 30% increase. But the big issue that we are seeing right now is our hospitals, mainly our ERs, being at full capacity. It does not seem to be COVID related for all of the hospitals to be at full capacity. That being said, obviously COVID and the furloughs and staffing changes have played into it as well. So it's a little too multifactorial to say exactly why we are seeing that increase in our penetrating trauma for our region specifically.
Yeah. Okay, good. So, I mean, this is it. Stein and I talked about this last week. We're going to get a question out. We're going to make it simple. Just again, we'll try to do the same, I guess, monthly totals as we did with cardiac arrest for penetrating. It'll be interesting to see that it lagged behind everything and then finally reared its ugly head later this summer. And as Glenn's pointed out in the past, you usually do get increased, shootings in the summer times. And so, so that's not a total surprise in some respect, but this is really extraordinary. Like, again, what Glenn and Crawford had described and what you're describing as well, because we're comparing it to the 2 years. So if everybody agrees with that, let's get as many cities. By the way, we are at 49 cities already. We have one more city I think we're going to be able to get, and we'll be at 50 cities for the cardiac arrest paper, which I'm writing up this week and going to be sending it in within, I hope, a week. And it's extraordinary. One of the things I will tell you guys off the record, so to speak, here is that I think it was a canary in the coal mine. I had first heard that March 1st, you know how many people had died from COVID? At least that was let's say, addressed or was stated as being a COVID on March 1st. March 1st, think about that. We had our first meeting of the Eagles here on February 20th. March 1st, only 2 people, I mean, it depends on who you say, 5 people, 2 people, 1 people died by March 1st. You know how many it was by April 1st? It was still less than 2,000, like something like in the 1900 range and all that. But remember, that's the people they documented as having it. We saw these things starting to climb as early as February and definitely into March in all these cities, particularly Milan, particularly New York. The numbers were starting to go up, but they didn't get counted in the deaths, but we think they were directly related to the COVID. So it's going to be an interesting thing that we're going to put out. So thanks a lot. This one is a little tougher. I just don't know about the trauma stuff, but we'll have to follow it. So just before I'm going to do something in a second, but before we get on, Nick, you're there. I just want to make sure I'm going to be introducing you in just a second. Is Mark Conorado here? I'm going to have you do the intros. And before we get to you guys, I want to see if Mike is with us. Mike Osterholm is supposed to be talking to us. Yeah, Mike's on.
I'm here.
Yeah,
I'm here.
so Mike, I'm going to go ahead and put Peter on, talk a little bit about his antigen study, for like 2 minutes, and then we'll launch into you.
Okay.
So that you have something to react to. And then but let me just take like 30 seconds, if you guys don't mind, to introduce Nick Simpson. He's our latest member of the group. Mark, can you do that and give us a 30-second blip, and we'll welcome him into the group?
Certainly, happy to, Paul. I'd like to introduce Nick Simpson. I had the great honor of having Nick as a resident, and then also he worked with me for a couple years at my shop before transferring back to Hennepin County Medical Center. As you know, I am no longer a medical director for my ambulance service, and Dr. Ho, who was in charge of Hennepin County EMS, has moved up higher into the organization. So Nick has taken over, and Nick will be an excellent resource and excellent representative for Minneapolis for the Eagles.
And let me cite that Mark is not leaving us. We are a team, and Mark has been part of it and a strong part of it for so many years. And that's why I used him for representing Minneapolis over all those years. But it really was a hospital-based system. And in Minneapolis proper itself, it is from Hennepin County based, and that's where Nick's out of. So, I don't know if Nick, can you come on and just say hello and say hello? You're originally from the Western Virginia area, like Charlottesville and so on. And I think you're originally from Winchester, if I remember correctly. And you got a wife, couple kids, and like at least 3 of them that are in a great range and all that. And we wanted to welcome to the fold, as I talked about last night. So if you're there, you want to get on?
Yeah, I'm here. Thank you so much for having me. I'm excited to be part of this group. I've often heard of the Eagles, but it's really great and an honor to be a part of the Eagles group now.
Okay. Yeah. So be prepared. You're going to be getting a lot of emails now. Okay, now that you're here. All right. Well, listen, thanks so much. Peter, go ahead and do that so I can get Mike on as soon as possible. Okay. Peter, if you can give us your quick rendition of what you've been doing. Thank you. I thought it was about anti-gin. You're for vodka and not for gin. Is that right?
I love gin.
Knows Peter Heavy, who's our pediatric specialist, but also is becoming one of our specialists on testing out there. He says he's testing thousands of people in the South Florida region. He's the chair of the Greater Broward Emergency Medical Services Medical Directors Association, and I could go on and on. But Peter, thank you very much for coming on.
Yeah, basically Paul's trying to say I'm a jack of all trades and a master of none. So that's just me. So I'm really doing this to set up Mike Osterholm because this is kind of his wheelhouse, but I wanted to show you just a couple things. Most people know Quidel, and the data I'm about to show you comes from Jeff Coleman out of Advent Health, just to kind of show you what these tests typically will do. Again, this is their EUA showing an 80% sensitivity, 100% specificity. And then the Advent Health system, validated their own data, coming up with 76.24% sensitivity, 98.77% specificity. So when Mike speaks, I'm sure you'll hear that, all these numbers for any antigen test are, they're not great. They're not in the 90s, and they'll probably never be in the 90s. So this is kind of more what you'll see. If you're at 80% or higher, you're probably doing very good. This is new on the market. This is another test that requires another device. But again, these antigen tests are coming out to the market. As Paul mentioned, and actually, this is the one that I wanted to show you some data on that Mike's already been on the news for talking about this. But this is Abbott's Binax Now antigen test. What was interesting, when you look at their data, you can see here that they're showing a 97.1% sensitivity and a 98.5% specificity. Those numbers are awfully high. I'll let Mike give his take on that one. But
patients total evaluated in this?
102 total, only 35 positives. Yeah. Correct.
Okay. Interesting.
Small numbers. I mean, for example, in my antigen study, I'm going to get over 1,000 patients. On my antibody study, I had over 1,000. I had thousands of patients.
Yeah.
That we got the FDA EUA on. So I'll show you my data. So this is the test that I'm evaluating. No machine. Again, very similar type of test. I only have 1 week of data, and here it is, 68 total patients. and we're at an 82.35% sensitivity. We're going to be rolling this out here in Palm Beach County over the next couple of weeks to get hopefully over 13. My goal is 1,300, but I'm going to stop there and really have the real expert in the house give his opinion on it. But thanks for having me show my stuff. Thanks, Paul.
One of my reactions is that, you know, whether you're going to be positive enough with an antigen test probably has to do more with the timing of it, like everything else. Is there a window you've got to hit?
It is.
And how
it's
do you
a sweet spot?
It is, okay? What is that sweet
Yes.
spot? So I think that's something that Mike can help us with, et cetera, and understand where we are. So again, if anybody doesn't know, the you know, the director of the Center for Infectious Disease Research and Policy, namely Mike Osterholm, then what planet do you live on, right? And Mike's been just totally our guru. I speak to a lot of people, other epidemiologists, and he is held in the highest esteem. So we're so glad that he's part of the Eagles with us today. So I've asked Mike to address a whole bunch of stuff. I might interrupt him every once in a while, but for the most part, the first question I have for you, Mike, is in the past, you've told me, like, wait till October or so, or November to get your flu shot, because the peak season is usually January, February. So make sure you're primed. Your 6-week, 8-week part, you know, peak is happening right about then. What do you advise for this year? Should we do it earlier? Should we do it later? What are you suggesting for us?
Well, you're really asking two questions, Bob,
okay.
And thank you for having me. The first question is, when is it possible to get your test granted? The challenge in interfacing in the clinical setting. The second question is, when does it make most sense biologically to get it? The second question first, it makes better sense to get it closer to the actual flu season, because we clearly have demonstrated waning immunity at 3 to 4 months post immunization. We have a whole series of studies that show that it drops off after that time. So people getting vaccinated in August and September obviously have some challenges when the flu season comes along in late January, February in terms of protection. So I personally try to get mine basically kind of just before it starts, first week of December, last week in November, if possible. But this may not be possible given what may be happening with COVID-19 and people having access to clinics. So that's the first one there. I think Peter, thank you for sharing your data. Peter and I had a chance to talk.
Well, let me interrupt you for a second. So then when's your prediction about flu? When's it going to happen? Is it going to be early, late, or the same time?
I'm not sure we're going to have any flu this year. And I don't know why. And what I mean by that is, you know, we've had a relatively incredible season for the Southern Hemisphere over the last 4 months, despite the fact that there were countries like Australia and New Zealand that didn't do a lot of effort to limit COVID-19 transmission in their island status. So they weren't doing things like masking. They weren't doing things like mandatory physical distancing, et cetera. So they couldn't be accused of having altered it around COVID activity. And yet we saw almost nothing. This is probably the lowest flu season we've seen in the Southern Hemisphere in the last 30 years. Even in countries like South Africa, which did ultimately have a real challenge with COVID, it's just incredibly low. So, you know, I don't know what it means for this year. I don't know how much impact COVID itself has on this. We just don't know. So, you know, we'll have to wait and see.
Yeah, Mike, this is sort of just a, you know, common sense man on the street view from me, is that, you know, because we are getting people not traveling as much, because we are masking more, we're washing our hands more, all things we told them to do for years for flu, people are doing. So maybe it's going to be relatively less of a hit. So I don't know. We'll see.
Yeah, we'll see what it does. You know, one of the things I think most people don't realize is on a given flu year, really no more than 20%, that's as high as I've ever seen, of the actual respiratory transmitted agents are actually flu. 80% are all the others. So we'll see what happens with the other ones. And with the panels we're running today, the BioFire panels we're running today, we now can pick up a lot of additional respiratory pathogens that we didn't see in the past that were actually occurring. We just never diagnosed them. So we'll see what happens with all of the respiratory pathogens.
Good. Okay, then let me move on to addressing the issue about the antigen testing then. What reaction to what Peter was doing and what's going on with the Abbott test, et cetera?
Yeah. Well, no, I think that Peter's doing is great. Very encouraging. And I think he's coming away with some very important data. You know, we have for years actually told people do not use the Abbott Binox test for flu. It's right on the CDC website. The sensitivity of that is somewhere between 50 to 70%. We've had challenges over and over again with it. as a lateral flow test. And so the sensitivity is so bad that basically should never be used for diagnostic purposes. If anything, surveillance / sampling kind of testing. I think the same thing is going to be true here. We have several labs working on it right now. You know, when you put data in, I think and Peter, thank you for showing that slide, because most people don't believe it. That thing got an emergency use authorization on 35 positive samples, which, by the way, the lab can actually know the CT of that sample before they ever put it into the panel. So the bottom line is, if you can't get most of those positive, boy, you really have a problem. And yet, and FDA does not do anything to confirm those data. They take those at face value. There's no lab testing going on. So when Abbott put that in, if you go back to the flu data actually says in their package also 95% sensitivity, and yet I've seen no lab that's ever been able to get above 70. Most of them are between 50 and 70. So you can use them, but I wouldn't trust them. The irony of it is, we have right now is because of the way it was approved with the emergency use authorization, it is only for diagnostic purposes, clinical purposes. The one thing we'd tell you never to use it for. And so technically it'd be an off-label recommendation if you used it for screening.
So let me ask you this, what is the window for antigen being positive? If you have the absolute, you know, gold standard, what is the window in which you got to capture the antigen test for it to be positive?
It's in the same window as PCR itself, you know, in the early stages of infection, you know, possibly 2 to 3 days before onset if you have onset, and then for up to 5 to 7 days afterwards. There's an article in this weekend's issue of the New York Times suggesting CT issues on PCR were a problem. That article is being basically reevaluated right now because there was evidence that there may have been data that were, how should I say it, cooked in the study that was in that article, that we surely do not see half of all the CTs higher than 35 that are called positive. In fact, data from 4 different state public health labs have combined it. Now it's less than 5% are in that category. So we'll have to see. I mean, so I think right now it's early on. You'll pick it up if it's going to be there.
Yeah. By the way, just for some of our audience that will get listening to the recording later on, can you just briefly tell them what CT is and how that you know, how that relates? And,
it's cycle time. Basically, every time you do a cycle, you amplify the genetic material. So you go from 2 to 4 to 8 to 16 to 32. And the number of cycles it takes to actually get a hit, then it gives you a relative sense of just how much genetic material is there. It doesn't tell you whether the virus is there. It just tells you the RNA of the virus was present. And so CTs typically lower than I should say lower than 35, meaning below 35, are all considered positive in most instances. Those higher than 35 are not. Meaning that by the time you hit that cycle time, you should have picked it up by then.
Yeah, that's great. Thank you for taking the time to do that. By the way, I may want to interrupt because a lot of people are asking about discussing the vaccines, and I don't know if you want to take the time to do that now.
My worst nightmare right now in public health in the 45 years I've been in the business is this situation right now. I think that we are going to see an October surprise come forward. It likely will be approved as an emergency use authorization on the October 22nd meeting of the FDA. I can tell you that there are many of us in the public health side that are absolutely convinced the data will neither be comprehensive or even minimally acceptable for approval of a vaccine like this. And if it is done for whatever reasons you can imagine might be done, you've already witnessed the problems with lab testing at FDA, hydroxychloroquine at FDA, remdesivir at FDA, plasma at FDA. Think of all the challenges we've had just in the last 4 to 5 months, and there really well could be a vaccine. Imagine if we were in a situation where we have a number of leading public health folks come out saying, no, this vaccine is not one you should take. The public is going to be so damn confused because already a third of them say they're not going to take if it were a safe vaccine and labeled as such. So I think we're on a collision course right now with a real crisis because I do believe that any vaccine that would be approved between now and October would absolutely be inadequately evaluated. There's no way. I mean, You know, you don't have to be a smart farmer to know if you plant your corn in April, just because you plant twice as many acres, you can't harvest it in half the time. You know,
Yeah.
it just isn't going to happen. You got to, and we're so far short of the data we need to really evaluate these vaccines.
Let me interrupt you for a second. Jim Augustine, you were going to bring up something about vaccines from the IAFF, IAFC, International Fire Chiefs and Firefighters Association. What's going on there briefly, just so we can fill Mike in?
Yep, that's that is very important. They're beginning to lay out their plans for vaccinating both their own people and their public. And this morning's Wall Street Journal article, very nice chart about development. They've got 3 organizations apparently moving towards that October filing date. This was an article that was discussed this morning. Mike, did you get to see that? And are there leads? It looks like there's very, very different technologies going into each of the vaccines.
Yeah, thanks, Jim. It's a real challenge. First of all, even with the amount of vaccine that could be produced in advance of the actual approval, the systems are not yet in place to distribute the vaccines, nor do we have a prioritization list. You all might think you're on a priority list, but get in line with about 10 other groups that think they're on a priority list.
Yeah.
And so we know that basically we're going to have one hose to basically provide vaccine from initially, and it's not going to be nearly enough to fill what people might want. Now, having just said what I just said, it may very be possible that a lot of people aren't going to take the vaccine. So we'll have to see. So we have 4 different groups right now that have been empowered with coming up with priority groups for vaccination, which we still don't understand exactly how those are going to be brought together and synthesized into one final group. Who's going to approve it? The ACIP has basically largely been taken out of it in that regard. They've been told that they will not be the group that will approve where recommendations go, which is a historic difference. So I think at this point, Jim, we just don't know what's going to happen, and we're so close to October 22nd. I mean, you know, you can't build the Empire State Building in 3 weeks. And I think right now we're feeling like even if a vaccine were to come, the infrastructure isn't there to support it. And at the same time, of course, coming back to my original point, a lot of public health people won't support it.
Yeah. Okay. So listen, thanks. And by the way, we cannot thank you enough for just being here and bringing.
Yeah, no, thank you. You had one other additional question, reinfection, which I think does bear some comment if you have time.
I want to get into that, but I just wanted to,
no, thanks.
You've been a real lighthouse for us and a real anchor, so thank you so much. Okay, so let's go ahead. Let's talk about reinfection and maybe some of this issue. We could maybe throw in the T-cell immunity. I'll give you my opinion about that, but then the long haulers thing, I think, is the thing we're all focusing on now. So go ahead.
Oh, great topic. The reinfection one is one we've known about all along in terms of coronaviruses and the potential for not developing durable immunity, like we see with many other pathogens. And so we've had 8 cases in the last 9 days come forward where they've absolutely been confirmed to having had 2 separate infections. Viruses were different. They actually had virus. Now, the number of people who've had reinfection likely is much higher, because most people would not have had a virus isolation for 1, let alone 2 different episodes that would allow them to distinguish the viruses from each other. I have data on 4 of these cases that 3 of them, clearly the individuals had relatively mild illness at the beginning and had even milder illness with the second, and each had a unique reason why they had virus isolation done. But there was a case, a 25-year-old male from Reno, Nevada, who had milder illness initially in the first episode and was much more severely ill with the second episode, I think 3 months later. I don't have the exact date in front of me, I remember. But that is one that the coronavirus experts have all been talking a lot about, because we've not known, would in fact reinfection be a milder illness because of some residual immunity that would still be there, including T-cell. And this one case surely is cause to worry about that. Imagine if we don't get durable immunity and what would happen. Yeah.
And by the way, just out of curiosity, of the cases you have followed, do they come back with exactly the same kind of symptoms, or is it a whole different symptomatology?
No, at this point, same kind of symptoms. In fact, 2 of the individuals that are in the group I just mentioned had such mild symptoms that way they were picked up. For example, the original case from Hong Kong was picked up because he came back through customs. And one of the other cases was picked up through a contact tracing study that was done in which they got tested again and just found to be positive. And so then they looked at the virus again. So I think at this point, the reinfection one is really a wild card. We just don't know. And it surely could cause real challenges going down the road if 3, 5, 6 months, 10 months later, people are vulnerable again to reinfection, and particularly not knowing exactly what the clinical spectrum will be.
Okay, so but as far as you know, that's why I wanted to see if you could tell me that if they had a problem with smelling or something, that they come back, they have a problem smelling the next time. Is it an individual specific hit, or is it all over the map? That's all.
It's all over the map. I mean, there's just one case. You can't make a international policy on one case, but it's enough to be concerning. This was an otherwise healthy young male. This was not somebody underlying, immune deficiency or other compromising, a comorbidity. And the fact that they did have much more severe illness is a challenge.
So I've told you before a study that Meg Marino from New Orleans and Peter Antefi from Coral Springs did, in which they actually were looking at people who had been positive for PCR, and then within a few weeks they were tested. And in both cities, using different tests at different times, they found in different populations, etc., they found that 30% of people didn't develop antibodies. Okay, so that's the traditional thing that we're looking at. And it was interesting because it looked like they had milder symptoms. They tended to be more male, and they ended up, more importantly, being of a much younger age, which we saw, I think you've told me this in MERS and other things before. Mm-hmm. So is it because maybe they don't light up the B cells, because we don't need no stinking B cells because they are, because the T cells are working? Is that what's happening, or what can you tell us about that?
We don't know.
Okay.
We've been looking at T1, T3s, trying to understand what the difference functionality is. We know that we have responsive T cell to coronavirus infections from previous, but so far no one's actually been able to demonstrate they're functional in protection with a subsequent infection. So at this point, we don't know. We're looking at this in animal models too.
Yeah.
And the animal model data, by the way, supports the human observation. That's what gave us concern. 2 different groups challenged macaques day 0. Some of them were challenged again at day 30, having been infected and ill. And at day 30, everyone was protected. Yeah. Some then didn't get challenged again at day 30, but then let them go to day 90, challenged them at day 90, and every one of them became infected again at day 90.
Okay.
So it just gives you some sense that we had reason to suspect this might happen.
Okay, so my last 2 things we'd like you to address, if you can still have the time for, is the long haulers, and then also give us an idea where you think you are. Are we in the 3rd inning yet? And is this a double header? That kind of thing, right? So.
Long haulers is going to be a very significant issue. I think the percentage of people who are having these long-term symptoms, a chronic fatigue-like picture, ask the radiologists who are looking at these chest pictures of these people. Let me just give you an example of one right here in my hometown. A 35-year-old nurse who became infected in late March. Milder illness, was off work for 2 weeks, just basically recovering and trying to clear infection. Basically cleared infection, tried to come back to work, and has basically been on disability since that time. She's now on oxygen in her home. This is since March. And she had no underlying health problems. We are seeing more and more cases like this of people who really are having big challenges.
Yeah. And so is it all over the map in terms of what their chronic symptoms are, by the way?
Yes, a lot of fatigue. I mean, a chronic fatigue-like syndrome picture, but as you know, there's been the cardiac abnormalities found. These chest pictures are just remarkable. I mean, you some of you on this call know this better than I, but I mean, these have been very, very substantial radiographs. So, we don't know.
Ken Shepke, you've been studying this a lot. Anything you can add into this?
Yeah, I'll tell you, this seems to be multifactorial. And like Mike said, we don't really know the causes yet, but just digging into some of the biochemistry behind this, there seems to be chronic inflammatory problems, chronic problems with the microscopic thrombi, and perhaps problems with mitochondrial function, because energy seems to be an issue.
Yep.
So I've been looking at various ways that we can assist mitochondria. This is not an area that's been very well studied. We've had problems with chronic fatigue syndrome after other viruses, but never to this extent. So I predict that there's so many people now that we will be getting a new branch of science studying this phenomenon. And I think we're just starting to see the tip of the iceberg on that. There's definitely ways to deal with each one of those branches, whether it's the immune function thing, the blood clotting thing, or whether it's the mitochondrial thing. But none of this is very well-developed science. Interestingly, we see some of these symptoms with statins. When you look at statins, they give you these muscle aches and pains. And one of the theories behind using CoQ10 on that is that statins interfere with your body's ability to recycle coenzyme Q, which is useful in mitochondrial energy production. And when you have intramuscular cell energy depletion, you may get muscle aches, which is that along with the fatigue are two of the major things that these long haulers are discussing. So when you start looking at some of the things like people are mentioning, quercetin, CoQ10, nicotinamide riboside, these things are all designed to assist the mitochondria into making extra energy. And whether that's going to work or not, I don't know. Nobody knows. And then N-acetylcysteine on the blood clotting standpoint. N-acetylcysteine for two standpoints. Number one, it'll help break down some of the mucus. There may be some, we know it works for COPDers, but it may also work at the microscopic blood clot level too. We know N-acetylcysteine can, in addition to Tylenol poisoning, actually is a mild blood thinner. So those are some of the things being touted right now.
And clinically, I was going to brought you up because you work for the Florida Department of Health. Part of it is also the issues that you're seeing everybody from pericarditis to muscle ache. It is all the different things. Like one thing you can predict about COVID is that's unpredictable, I would say.
Yep.
So Mike, let's turn back to you because you got to probably go, I suspect. And I'd like to see again if there's anything else you want us to know about, and also if you can keep us ahead of the game and tell us where we are. Is it going for a doubleheader? What inning are we in now, et cetera?
Well, I think it's unclear. I mean, we clearly know that this thing is not acting like a flu virus in terms of epidemiology. This is like a coronavirus forest fire. It'll burn wherever the hell there's wood to burn.
Yeah.
And I think the thing is that there's a lot we can do, though. And I mean, for those of you from New York, you understand. I mean, there's the one place in the world that was a house on fire in March and April, have done a remarkable job. We continue to see these very, very low flat rates for 14 weeks, days without deaths. We've seen that nowhere else in the United States. And for that matter, around the world, where they really got the case numbers down. Now, surely New York is not back to where it was. Everyone knows that. But I think that there is evidence that you can actually do a lot to contain this from becoming a house on fire situation. For those of us from the upper Midwest, I know I see a number of you on here, we're having real challenges right now. We're seeing very rapid spread. We've just reviewed the data for 4 upper Midwestern states. And if you took and scrubbed the name off of it and just looked at the percentages and cases per population, we're looking just like Florida, Texas, Arizona, and California did 10 weeks ago.
Yeah.
And that's scary. So, I mean, I think people just don't understand this. And of course, the college campuses, Paul, you and I have talked about this, we'd predicted 3 months ago that the college campuses were going to add substantial cases. We're seeing a fair amount of impact from Sturgis. There were people from 61% of all the counties in the United States at Sturgis. All that indoor air wasn't outdoor. It was the bars, it was the entertainment centers, it was the tattoo parlors. We're seeing lots of cases right now there. Minneapolis, St. Paul, Minnesota, I should say, we are now investigating, I think, our 58th and 59th bar-related outbreak in the last several months. Yeah. Some of them huge outbreaks. So, I mean, it's just transmission's ongoing. So we'll have to see, and what a vaccine does or doesn't do will dictate, how do we get to that sense of herd immunity through natural infection or through this? And then if we do get to herd immunity, does the damn immunity last? What does it do? And I think, so therefore, I don't know. I don't even know what game we're in anymore, let alone if it's an inning, a quarter, whatever anymore. It's crazy.
We've just got off the field and went to the bar. That's what happened. Hey, so one of the things I did want to point out is that I went back and saw when we were first having our meetings here about this, it was February 20th. Yep. And you were already predicting aerosolization at that time. And obviously, a lot of this is intuitive. If you're inside and talking to people loud in a noisy bar, you're going to be ejecting a lot more stuff, et cetera, versus if you're out in it. But still, the 6 feet thing, is also kind of a little bit arbitrary as well, I think, because the further away you are, it's like radiation. The further away you are, the better off you are. I mean, it's safer, but you could be even safer, you know, and so.
Well, indoor air is the key issue. I mean, that's why the protests resulted in very, very few cases.
Yes.
It was outdoor.
Yeah.
People say, well, Sturgis should be that way then. Well, Sturgis is outdoor until you get into those bars and sat there for 5 hours, or until you were in the entertainment center at the casino, et cetera, for 8 hours. That's what really has moved the Sturgis stuff on.
Okay, got it. Well, listen, this has been
Thank you.
We've missed you. This has been a great week.
Well, I miss you guys. I do. I appreciate it very much.
Actually, I have 2 or 3 things I need to talk to you about if you ever have any free time, like later this afternoon.
Send me an email. We'll forget it. Thank you, everybody. I do have to run. So thanks a lot.
No,
talk to you later. Bye.
Thanks, Mike. Appreciate it. Take care. Bye.
Thank you, Mike. All right. So listen, a couple things. I saw that we got Jose Cabanas. Are you there still, Jose, by any chance? Because we hadn't talked to you for a while, and I just wanted to see if there's any report from your area before we get to Brent Myers, by the way, since you're in the same area. Jose, are you still there? I saw you before. Maybe you had to get off.
Jose, you look like you're unmuted, but we can't hear you. So check your, there's no.
Well, in the meantime, while we're waiting for him to pipe on, if he does get on, I just wanted to point out, Brent, that we had long discussion, I mean, long, 15, 20 minutes before you got on, because, everybody wanted to get into it. And we had Mike Levy on and all that. One of the things that kind of came up was I sense a little sensitivity there, but I think we're not that far apart. Hey, Jose, we'll come to you in a second. Is that issue was a representation from NAMSP, and of course you were there with ACEP, et cetera. So we just want to make sure they reconnect a little bit closer and, and make sure that gets aligned. I don't think we're that far off when I look at where we were, as you know, with ASA and now where we are today with the statements that they put out. But I think the media are still looking at their original statements, et cetera. So that's kind of what we came to a conclusion about. And everybody said, let's do what we're doing, which is gathering the data, looking at it as what this thing works for in general, and then what was the issues with the delirium, et cetera. And I think you're already on that case. So thank you so much for what you're doing there. So before I get to you, Brett, let's talk to Jose real quick. Can you give us a follow-up of what's happening in the Raleigh-Durham area, Wake County, okay?
Thank you. Hope everybody's doing well. Thanks so much for having me here today. No, just a quick update. Like everybody else, we're just managing through. We actually are seeing for the first time, a sort of a decrease of case counts and sort of a number of cases and hospitalizations in our community. So we're hoping that's a good trend that keeps going forward in that direction. We know the governor's supposed to speak up today, where we're expecting he's going to release additional restrictions for the state. So we'll see how those things go. But right now, we're just managing like everybody else, and our call volume has come up, not to the same levels before February, but we're still seeing a trending of call volume up, and some interesting numbers of additional penetrating trauma in our community, which is kind of atypical. But certainly when I have more data on that, I'll happy to share with the group.
Okay, got it. And then Libby, you had the worst hit right now, Libby Char out in Honolulu. And I know your tourism's down 98%, so you're getting hit economically as well. But what's the latest coming on from Honolulu?
So yeah, thanks, Paul. We've seen some big increases. Our overall numbers aren't high, partly because our population's only 1 million, but we're back in almost a full lockdown. And so far that's been looking like we're heading to at least a plateau. We're seeing about 200 new cases a day. Our test positivity rate on 7-day average is about 6% now. So fingers crossed.
Okay.
And our director of health just resigned.
For the state or for the county or for where?
Yeah, for the state. That's another oddity of Hawaii. We only have a state Department of Health. We don't have county health, and I think that's kind of problematic in a situation like this. So the city's really been trying to step up and fill some of that void.
Was there just were there threats, or the death threats or some kind of threats, or is it just like tired of doing this stuff? COVID fatigue, I would call it, right?
Probably a combination of all of the above.
Yeah. Okay. That's been a global trend that I've seen out there. So, all right. So let's move on. And then, hey, the person calling you, oh, that's Peter. Never mind. I think I know who it was. I was thinking the 954 thing. So let me go on. So Brent, let's go ahead and catch up with you briefly, see if there's anything new to add on to what I said. So Brent Myers has been from ESO and former, president of NASP, has worked really close with ASAP in developing responses to the ASA, et cetera, and they're collecting data now for some papers that we're hoping to put out. Can you give us an update then? Remley talked to us a little bit, but I just wanted to get your perspective.
Yeah, thanks, Paul, and sorry, there was just an unmovable meeting earlier, so I apologize about that. But, you know, where we are now is really trying to look at the outcomes of these patients, not just their pre-hospital, but, you know, do they survive the hospital discharge? What are the factors associated with that? We have different looks, one of which is all patients who received ketamine in the pre-hospital environment. We're separating out RSI as a separate thing because obviously that's not a ketamine issue per se, so that's going to be evaluated separately. And we're also looking at everybody that received sedation IM who had any indication of agitation or physical violence as well. And then the final thing is we're looking at the outcomes related to a REM score so that we can give some relation of how risky this patient's pre-ketamine status may have been and put that into a context. So there's a lot of data analysis going on so that we can approach this from an evidence-based manner rather than anecdotal manner. And that's where we are. So thanks, and sorry I was late.
And Brent, listen, I just want to make sure I'm always making sure the left hand knows what the right hand's doing. I got a hold of Craig Ellis, and I think many of you remember from the Eagles meetings that Craig Ellis from New Zealand, he's got the data for the whole country. And he actually specifically did a 5-year study of ketamine use. He was responsible for it nationwide. And for about 5 years, and they had like 3,000 cases, of which about 1,000 were for what we would call behavioral. And he just had no issues whatsoever. So I asked him to please put something together, send us the data. And I'm going to try to ask him if he's sent it to Sandy already, which I asked him to do. That you know, they'll also send you a copy as well, so you can, you know, you're in the loop as well. So just if you haven't heard from me or you don't have his email, just let me know. I'll track him down today. They don't get up for another hour or two. So all right.
Oh, great, thank you much.
All right, no, thank you for all your work and all that. Let's see, I'm trying to see if there's because we only got really a couple of minutes left. Hey, I do see Remley on the phone there, as we said before, and I just want to point out for everybody, if you don't know that, because the meeting coming up, and I may bring it up again. But first of all, Lauren Maloney, who's been helping us out, although now that she's a faculty member, she has 0 free time, you know, and you know how that goes over at Stony Brook. But I just want to let you know, she had her first paper put out on an airway management innovation that showed up in the Biomedical Engineering Society journal. It's Annals of Biomedical Engineering. But anyways, I'll try to send a copy to it. So it's kind of cool because she did a really neat thing, and she's a first author and all that. If you don't know about her, she actually won not just 1, but 2 resident awards last year at SAM. So she's been a really great contribution to us, and particularly what you'll see what she's doing with the cardiac arrest stuff. But mentioning Remley, I do want to say is that this year, the article that was the research project that was picked as the research winner for EMS World for the International EMS Research Symposium. Remley won it again. She won it 2 years ago. Here she is again. This one's assessing the impact of the COVID-19 pandemic on EMS transport patterns for patients with suspected acute coronary syndrome, so which has been very useful for some of the things that we're going to be putting out here in the next week or so. But anyways, just congratulations to the team. Great job, and really cannot thank you enough for the contributions you make here. You know. So,
thank you so much.
So Erica Carney says Remley for president. Okay, now are you Law and Order or? All right, listen, thanks a lot. Good job. Okay, that's cool. All right, let's see who else is on the list I want to talk to. Let's see. We talked to, I think we got a lot of the key people we need to. Scott Gilmore, I just always love having you on. And so if you don't mind, can you just, what's the latest from St. Louis?
Not a whole lot new to report from here. Our positivity rate's 7.3% for our testing, but our reproductivity numbers have gone down. We're at 0.66. Like everybody else in the country, or a lot of other people in the country, our homicide rate's up 40% for the year. So we're seeing the same trends a lot of other places are seeing.
Yeah, okay, got it. Hey, and I guess since Hillary's been a really great support, I want to mentioned EMS World's coming up. Hillary, why don't you tell us a little bit about that? And so we make sure we get it out to the audience on this recording as well. Okay. Sorry I didn't get you earlier. I should have. I don't know if Hillary's still there. Maybe not. But anyways, for all those of you, I think EMS World is going to be coming up the week of September 14th, I believe, because we're going to start with the resuscitation. I think it's a future resuscitation meeting that we're going to go on for. A lot of you are on for those 2 days, and just want to make sure everybody was aware of it. And Hillary, I'll try one more time, gone here. And then—
Hey, Paul, I stepped away. I apologize.
Okay, yeah, I was just saying it's just an opportunity to let everybody know about EMS World. There's anything they need to know about to sign up or get the word out or whatever, because you've been so supportive of us, and particularly the resuscitation, future resuscitation meeting. So
I appreciate that. Yeah, that's the 2-day conference that Paul and Keith Lurie are putting together, the first Monday and Tuesday, and then the main conference is Wednesday through Friday. We've got good rates for students. So if anyone on the call wants to offer the rate to an EMS student, that's $99 for the 3-day conference, and it's basically on demand for the whole year. So they get access to all the classes for the whole year for CE. And then we have good group rates as well. So yeah, registration will stay open up until the 14th.
okay, got it. Well, thanks a lot then, and really appreciate your help as usual. Hey, AJ, on the EMS today, and you're still involved with that pretty heavily, as far as I'm concerned. And you guys are putting out a nice report about that particular future resuscitation from a previous one in Paris, I think, right?
Yeah, it'll be out within 2 days. It's a beautiful 56-page PDF full of a lot of information that a lot of the Eagles were involved with from our Paris meeting.
Yeah, we'll try to see if we can, and once it comes out, let us know. We'll try to send it around to the group as well, okay?
Yep.
Then you guys are still formulating plans for a in-person meeting. It's going to be in San Antonio, is that right?
Yeah, it's still planned. It's still planned as an in-person, and the program will come out shortly.
Okay, good. And David Miramontes, are you prepared for prime time here?
Bring it, baby, bring it. Voice is louder. I'm ready for action. Let's go.
So anyways, well, that's great. That's good to see. Hey, it sounds like you're doing well, right? How's the recovery going?
Well, we hit a little road bump. I got a weird infection, so I'm gonna get a med port, and I start 3 months of antibiotics tomorrow.
Is it an odd bug or whatever?
Yeah, Mycobacterium abscessus.
Get out of here! Oh golly.
Yeah.
Yeah, that makes sense, because that's the only thing that would show up this early. So that's terrible. I'm sorry.
Yep.
So,
but it's fine. I'll get through it. I'm still working. I'll continue to work.
So what do they use for that nowadays?
It's 3 drugs. Zithro. I was on Zithro, linezolid, Bactrim, and amikacin inhaled. And tomorrow I start tigracillin, amikacin, and Zithro.
Yeah, Jesus, unbelievable. Well, keep drinking fluids, okay?
Got pissed off because I dodged chemo with the cancer. Now I'm getting this crap. So there you go.
Okay. Well, listen, great to have you here. Hey, so let's go from youth to beauty, right? And RJ, I just haven't talked to you for a while in St. Paul. What's going on before I get everybody off here?
Nothing really. We're flat. We're at about 5.5%, and nothing is happening really.
Okay, good. Hey, RJ, remind me, how many years have you been the medical director for St. Paul Fire Department? I always love that part.
9 fire chiefs.
Yeah. we won't ask you how many years. And then while we're up in that neck of the woods, I'm going to run over to Detroit for a second. Rob Dunn, because you've always been busy. Can you get on with us real quickly and just say hi and tell us if there's anything new in your realm?
Yeah, hey. So fortunately right now we are in pretty good shape. Actually, our city proper positive rate is below 3% for 3 consecutive weeks. That's the lowest it's been since we've been measuring it.
Nice.
Southeastern Michigan as a whole is about 4.5%. So yeah, kind of enough about COVID. Obviously, we've been fielding a lot of questions about the ketamine issue. I was on for the beginning of the call, so that was really good to hear some of that perspective. We've had in our protocols for a while. We track its use. We haven't really had any issues. It was a great addition to our protocols a number of years ago. But we don't want politics to overwhelm good science. So I appreciate the stuff. I messaged Remley back, in particular that article that she shared. If you haven't looked at that, you should look at it, because you got to remember the baseline, right?
Yeah. Now, I assume, are your shootings up as well, since all the other large cities seem to have that?
They're a little, if we look at the last 5 years of typical August, they're still within kind of expected confidence interval for us, which is unfortunately a lot. Okay.
So you can't improve upon success then. Okay, got it.
Yeah.
Okay.
Exactly.
Let me turn over to Jim Augustine. Just make sure there's no further reports from the master. And Jim, should we say anything about what happens Friday and Saturday?
No.
Okay, good. I'll leave it at that. Okay, good.
Nothing further, Paul. The IFC, IFF are waiting for our leadership when it comes to assisting in vaccinations. That was the bottom line.
And when you say
great
leadership,
insight from my
when you say leadership, who are you referring to? To whom are you referring?
The medical directors.
Okay, got it. Okay, good. Well, then let's put I'll put that on our radar screen of things that we need to be paying attention to. Okay. Anybody else that I haven't tapped want to pipe in here and say anything before we get off? It is the witching hour, so to speak. But anybody else, please, if there's something to report I want to talk about. And of those of you who are on, I wouldn't mind getting a really good, brief 5-minute reports on something new that you're doing or something that's going on in your area. That'd be kind of fun for the rest of us to hear. Like Peter did the ephemeral talk last year about ephemeral IOs, or today's trauma talk from Crawford. I'd like to get more of that from you guys if you can think of anything. So and the other one that Peter did today on the antigen testing was kind of interesting. So anyways, that's it. So anybody else want to say anything?
Paul, congratulations.
Oh, what's that? Oh, yeah. Okay, about the county commissioners today?
Well, two things: an AMT recognition, and then your recognition by Dallas County.
Yeah, that was really nice today. They're good friends there.
Fun. I got to listen in. So congratulations, well deserved.
Okay, good. Well, thank you for. It was really kind of nice to have someone to practice the talk with just beforehand. I'm glad they had that delay, so appreciate it. Okay, so it's kind of cool. I think it went across okay. So that was the feedback I'm getting. So all right. I love you guys dearly. I miss y'all. And see you next week. Welcome back, my friends. This show that never ends. See you later. Bye-bye.
Thanks, Paul.
Paul, thank you. Thanks, everyone. Take care. Appreciate you.
Thank you.
Okay.